Much, Professor, same for you.
Thank you, sir. I'm really honored and really thankful to IOA for giving this prestigious honor to me. And I have the privilege of being with this great man at his place way back in 1993 as a JJ Fellow, and to have stayed for at least 3 days, 3 nights at his house, and we have enjoyed the blessings at that place. So I'm really honored to receive this lecture on his name. Thanks a lot, sir. The disclosures that the work on avian has been sponsored under the research schemes from AAGO Hong Kong and AIOD France. As we understand, when we talk about avascular necrosis, the various causes, the various pathologies, it ends up in a collapse of the femur head. And there is a very good paper from India published in Lancet on the etiology of finding out the role of homocysteine and concomitantly reduced level of vitamin B6 and B12 as a report, one of the excellent reports in the Lancet. Now, looking at the profile of sickle cell in India, there is a query what happens in sickling vis-a-vis the other avian happening due to steroid or due to the alcohol. In all other conditions, it remains non-inflammatory, while in case of sickle cell, it is inflammatory histopathology without sepsis or without alteration as it has been perceived. While diagnosing a case of avian, we understand there can be, I'm specifically labeling, there can be pain as a presenting features. While it becomes a very late feature in many of the patients, there are physical signs which can point out to the diagnosis. We do take an X-rays, and definitely at the earliest stage, X-rays may be negative, and we have to go for MRI to get the confirmation. And these very X-ray pictures has given us the classification of FICET in defining pre-X-ray stage to the subsequent stages, whether stage 1, 2, 3, and 4. But MRI is diagnostic, and very typically a single band like area of low signal intensity on T1 and second high signal intensity within the line seen on T2 images. What is more important is to define the amount of involvement as can be seen on MRI, and this amount is likely to be the prognostic in the outcomes also. And this is important, how much and which part of the femur head is involved, whether it is the medial part or lateral part. And we understand when it is the medial 2/3, it is the C part area which has got the bad prognosis. And this is one of the another concepts which have, they say, yes, we can define on X-rays the amount of involvement, but volumetric assessment of the avian is a much better method, but technically difficult. So we have eventually to rely upon the Kerbal angle by defining the amount on the images only. And accordingly, the ARCO classification has come, which along with the FICET classification gave quantification of the amount of involvement of avascular necrosis. As a part of differential diagnosis, we do rule it out the conditions of transient osteoporosis or BME. Now, there is a role of newer advances coming up by contrast enhanced MRI and many other features. When we look at SPECT scanning, it did not yield a better outcome vis-a-vis MRI. But few years back, we published the role of 18 fluoride PET-CT as a case report, first time in the world, because we found it to be useful and equivalent to the MRI. And subsequently, we studied in a series of 20 cases, each case showing the radiological picture, the MRI pictures, and the PET scan picture. And then we published this data subsequently as a series of cases and found it out that the agreement in MRI and PET-CT is 96.0%. And what was more important, that when we have got an MRI, subsequent changes after the core decompressions are not seen so early in MRI, while they are much better seen if we take a 18 fluoride CT in that scenario. And on this basis, we published one of the review articles on the role of nuclear imaging in avascular necrosis recently in 2017. In the day of today, we understand when get a patient, the diagnostic criteria, if it is seen on X-rays or if it is in the bone scans, on MRI or histology, any two positive criteria are likely to be diagnostic. Now, looking at the epidemiology, we understand steroids are one of the main factors, alcohol, and in the central belt of the India, sickle cell is a very important cause. The question comes, with steroid, is it dose related? Yes, a paper published in 2016 says it has got a very strong role. The SLE patient receiving more than 16.60 milligram per day prednisolone had 3.4 times higher chances of getting AVN. And likewise, kidney transplantations who are getting more of prednisolones are at a high risk. So it is a dose related thing. What happens naturally? A paper way back in 2010 said that if the lesion size is small, it doesn't reduce, it doesn't increase. But if it is a big, they are likely to increase or they are likely to stay static, but a reduction is never there. So the bigger lesions are likely to increase, so we cannot equate as a outcome similarly. Now I have this case which I operated way back in 1997 as a 3-month-old dislocation. Anticipating this will go for AVN, and at that stage at my place, in the small place, the MRI was not available, so we got an X-ray post-op. Now anticipating something will occur, we sent him to another place to get an MRI, and that was in 97. You see the MRI picture, it was showing, but patient had no symptom. We kept on calling him. In 98, he had no symptoms, MRI was showing changes. 2001, again he had no symptoms. X-rays were not very bad, MRI was showing the changes were increasing, but he had no symptoms. And he had no symptoms. As we go classically, we don't do any intervention. And he remained asymptomatic till 2005. And you see the 2005 picture. X-rays were bad now. But till he was able to sit and squat. And once he says he has no pain, what to do then? Why to operate upon? And it came in 2007 when he said, now my problem is significant, now you have to do something. And then we operated him in 2007. So it took 10 years, technically speaking, for him to be reasonably symptomatic to get a replacement. And so AVN does not mean an early replacement. It can be delayed to 10 years even. That's what I want to convey. Now, definitely there is always a wish to diagnose it early. And in a trauma case, one can make an attempt because you know the kind of an injury which has happened. So we tried a study aspirating during the open reduction time whenever we doing the neglected cases from the aspirate, looking at the aspirate morphology and subsequently doing the biopsy also, and we found it out. We subsequently followed these cases on MRI and we found it out that these changes can predict it. And then as we did their MRI, we did MRI regularly at 6 weeks, 12 weeks likewise, that their changes start at 6 weeks, but many of these changes disappear. So if we take an MRI at 3 months after the episode, now the changes are likely to persist. So we make a protocol that in any case of a dislocation where the chances of AVN are there, getting an MRI at 3 months is likely to be very definitive for the future course of the hip as such. And this is what we published subsequently in a publication way back in 2010. How early? This was after trauma, but after steroids, then we are not very sure when the changes start. So it has been seen in one of the studies we published in 2016 that this can start as early as within 2 weeks to 12 weeks after the start of steroids at that stage. Now that was about the etiology. Now come to the main topic, current scenario in management. Most of us feel restricted weight bearing. Advised him. We advised intervention at some stage, things were going bad. He says, I'll keep on using a stick and I'll keep on going. This is 11 years after that episode. He's still using this stick. You can see him sitting, he's standing. So definitely we are not really forcing. We say whatever you are comfortable because it is the clinical situation which is important. But if you go to the literature, both weight bearing group and non-weight bearing group have been studied and there is no difference pathologically. So weight bearing restriction does not affect the outcome. That's important. And when we look at the meta-analysis of this as a treatment, there is likely to be a high failure rate. So weight bearing restriction is not a modality of management. Statin therapy has been proposed in patients getting steroid, that you add statins along with, the chances are that the patient may not develop AVN accepted as such. There have been another that you do a hyperoxygenation, that might be able to help. Yes, there has been a report on that. Another in 2008 was use of extracorporeal shockwave therapy. It could be useful. Definitely there is a literature which says. In 2011, pulse electromagnetic field stimulation has been quoted in an experimental study to be useful in management. And just this year, there has been a very good review on systemic use of anticoagulants in cases where there were coagulation abnormalities, and they found there is a role of using in those specific situations that you can use these anticoagulants also. Iloprost has been defined into the publication last year that it could be useful in a specific set of patients as such. But we come to the main thing which we perceive is the bisphosphonates. It was proposed by Agarwala way back in 2005, and that has been quoted very often. And there have been a number of experimental studies and clinical studies which have favored the role. And there is a very beautiful explanation why it should be useful. This literature in 2014 has said that it takes 3 months to build up a new bone with an effective mechanical properties, but it only takes 3 weeks for the osteoclast to alter the mechanical strength. So by giving this, by inhibiting the osteoclast, we are likely to prevent that mechanical degeneration. So it should be useful. But when we look at the reviews, you look at this review in 2014, enough studies, they have eventually selected 5 articles out of 279. And what they say conclude, there is still a lack of strong evidence for supporting application of alendronate in adult patient with non-traumatic AVN. That was in 2014. And in the same year, another review article with about 8 articles, they said the findings support consideration of alendronate use for adult AVN, particularly with early stage and small necrotic lesion. That is a specific comment, they make it up. So alendronate might have a use, if especially in the smaller lesion, and it is said in the C type of a lesion, it may not have a use. Now, what are the surgical interventions? We look at the core decompression, which all of us accept as the primary baseline surgeries as such. The rate of outcome is definitely better. 84% in FICAT 1 and 65% in the stage 2 lesion is the outcome expected. And then we had a change in the management. Rather than making a bigger hole with the Steinman pin, we make a smaller holes. With those smaller holes, we are able to decompress that the edema in that area. And this has been validated subsequently in 2008 also, that it is a useful way. Whether this histology taken at the time of core decompression can help it or not, there is a very good article in 2017 that this histology, if it is a fibrosis there, it is likely to indicate the outcome. And if it is not there, it is likely to have a better outcome. But as far various pathologies are concerned, this histology is not able to give us the answer. I had a chance to attend one of the ARCO meeting as its member way back, and there I presented another work, because if you look around the literature, nobody has got a paper published on traumatic AVN specifically in relation to a core decompression, because we understand the pathology of a traumatic AVN is totally different as far as the occurrence is concerned. Now, whether it is useful or not, we worked on it, presented way back in one of the ARCO meeting in Chicago, with all the people who have got a name, who were participating, Mont and all those people. And subsequently we have published it out that the efficacy with the trauma as a primary etiology is not as good as in a non-trauma situation where there is edema and where this thing. Here there is a direct ischemia. So outcome of a core decompression is not as good. That is clearly, and this is the only paper in the literature regarding this thing. And these are the other studies which have actually the mixed of, and most of them are non-traumatic studies with a variable kind of a result. And we can expect that with the variable kind of a patient population within the groups, all these results can be variable, but definitely most of them are more than 50, 60 or 70% in that scenario. Now we look at the comparison of weight bearing versus core decompression, whether it makes a difference. Again, this is a meta-analysis of 168 citations. Eventually they selected 5, and what they say, The clinical goal of intervention is to save femoral head prior to collapse, and our result confirm that CD is an core decompression as an effective strategy in the management of AVN as such. This is the article we published in 2009, looking at all those, and it has been one of the highest cited articles from the IGA as such. Now, question comes, why not to combine core decompression with bisphosphonates? Whatever the benefit the bisphosphonates give, it is a simple therapy, the patients can lay it, its compliance is better. So we have been doing this thing also, and the literature says, yes, it is likely to be a good outcome in the combination of this thing also. Now, this combination we have used in about 90 patients on an average follow-up of 2 years, which means we don't have very long follow-up of all these cases, but with an average age of 34 years, in these 90 patients, the outcome of Harris hip score at around 2 years have been 84. The WHO quality of life score has been 85.5, and you can see the chart of all these patients over there. So not bad. But look at this was stage AVN 1, meaning by the earliest stage of these cases. Now we also appreciate that in AVN there is a derangement of the cells, apoptosis is high, and the cells are changing into the fat cells in that kind of a situation. So why not to augment it? And that was, as an orthopedic surgeon, well aware of a bone marrow acting over there, we think of it. And this is the first reference which I saw by Hernig as an abstract in one of the papers that it can be useful. And this is one of my friend who is in the audience also, who got a fracture acetabulum with a dislocation hip, reduced, operated upon, and after, because he got his MRI done, he started having AVN, and for that AVN, I gave him an offer that this is the only thing available with me right now, this is the literature, do you want to have it? He opted for it, we gave it, and this is 8 years follow-up way back in 2011, and today he's also with us in this very crowd, and he's still happy, he's still enjoying his hip as well as such. By 2005, there were more papers coming from Hernig and from the Ganges regarding this use. But when you look at 2006, the recommendations at the current concept review in JBJS, if you look at the multipotential stem cell, they say still there is insufficient evidence. And this was the time when with the available, we started a project around 2005 using these bone marrow cells. We had a set of 17 hips from steroids, 7 from alcohol, some idiopathic, and this way we used this very standard technique of fical separation over there as a part of my PhD product at that time. And this is one of those cases. You can see the x-rays, they look okay, Cushing syndrome, AVN bilateral hip, and we just did core decompression. Within 14 months, one of the hip had totally collapsed around, and another hip was on its way. As compared, another patient, idiopathic bilateral AVN, you can see the kind of a hip and these movements, see the x-rays, down there you see the MRI. This is after core decompression and bone marrow stem cell instillation. You see 6 months and you see 18 months outcome, and now this is his 7 years outcome. He's maintaining his hip as well till date in 2012. Another patient, 2007, Hodgkin lymphoma, treated with steroid, develops an AVN. Again, we go for those stem cell therapy at that stage, so-called, and this is her 8-year follow-up, maintaining. There is a little change, but her hip is reasonably okay. She has got all the activities around. Another patient operated in 2009. You can see the MRI pictures, and this is after 9 years of follow-up in 2017. He has got a good outcome of his hip. Another patient, 2007, SLE patient with bilateral AVN. You see the evidence, and this is in the 2009. One side was bad, another side we operated upon, another one side we did a core decompression of this thing. This is she in 2016, again after 9 years, maintaining that hip as well. Another patient, 54 years, 2007, he was painful. One side we went for a THR, one side we went for a core decompression in 2007, and this is 10 years follow-up. That hip is still quite okay. So looking at this kind of a profile doesn't mean every patient. This was a patient who did not do as well, and in 8 years you see the femur had collapsed on that side. Now, this was in this follow-up, but the earlier follow-up which we did as a part of project way back in 2010, we could see many of the hip surviving after marrow cells and not surviving after the core decompression alone. And this is what we published way back in 2012 as a randomized control study which we had done in Journal of Arthroplasty in 2012. saying this could be a role, and then by that time the literature was clear, yes, this has got a role. There were a lot of papers coming by that time, yes, this has got. We also published another review that yes, these stem cells are likely to contribute in the kind of a management. In 2014, a review article appeared with a big search of 215 articles. They selected 16 articles, and out of them, 5 articles, the clinical study. They quoted our paper, and they eventually said they could be useful. In 2014, another review also came with the same quoting of these 6 studies over there, and again they said it likely to be okay. In 2016, another review of 7 case control slides came, and they also looked at all those 6, including our study, and they showed, yes, these cells are likely to yield something. 2017, another review came. So every year we have 1, 2, 3 reviews coming up, and again they had now 11 studies, including our study and including one from the AIMS, supporting that definitely there is a role for stem cell in this kind of a situation. And you can see the another paper with the AIMS study and with our studies. Yes, this is likely to be, the cell therapies are likely to be useful at an early stage, at a stage 2, what we aim it at that they are likely to be useful. And by this time, we have already 90 patients where we have treated on this kind of a therapy, and with an average follow-up of 2 years, you can see the kind of a outcome. Now, look at the outcomes. They are not very different. But you look at the disease stage. That was stage 1, now it is the stage 2. So in the stage 2 also, we are able to maintain the outcome equivalent to the stage 1. That is what we say. And there is an excellent review by the same person who started the first publication in 2017. He said it, he concluded rather, and told with the osteogenic property with the bone marrow implantation, and these cells are likely to be useful. And definitely then there were attempts, why not, to make it further better. And in this kind of a tried combining BMP and into this area, and or making hypoxic preconditioning of these stem cells could be useful. And incidentally, in 2012, another paper came. They say, why not to culture them? Why not to put a culture cell into the area? There was a case report, and luckily at that time we had a facility in PGI having the culture of these cells, so we started using these cultures. And what was the difference? The difference was the kind of a change which we were waiting for few weeks or months were happening within weeks now. So definitely they provided us a much better, but because of my change from that place, I could not continue the study subsequently in that kind of a situations. However, the another paper came that rather than installation, you can do an intra-arterial delivery of the cells into that area as an option. Now, looking back at non-vascularized bone grafting options, yes, literature has been supporting, and this is the article in 2010, again supporting the use of bone impaction grafting through a femur neck window and finding the usefulness. An Indian article which said, yes, this is a satisfactory outcome if their patients are carefully selected and in an early stage of disease before the stage of the collapse. Luckily, we had by that time the availability of this tool from one of the American companies where it can go inside, spend out, curate it out, and could take it out, and we started putting the fresh, this cancellous graft along with these cells into this area. Subsequently, we had the another procedure, light bulb procedure, started using the kind of curettage, and with all these grafts, we did not go for a bigger procedure because of patients. We had 12 patients, again with the follow-up. Again, we were happy that our outcome was not different while they were little in an advanced stage for their disease. Then come vascularized fibular grafting, which is supposed to be the ideal thing. In the day of today, the gold standards in this management. And I have this patient with me. Way back, we operated in 2002. And you can see the kind of the condition when we did the vascularized grafting with the help of our plastic surgeons. And now this is 11 years later, he's maintaining his hip as well as possible. And we had done about 8 patients with vascularized fibula. And again, you can see the outcome is same, similar, still 83%, and quality of life still 86. And you see the disease condition, which was reasonably advanced in that situations also. And this is an older review of 2008, which says, yes, this could be one of the good options in this case area. Vascularized iliac graft is another option, which Professor Babulkar has really talked a lot about, and we have heard him, and we learned a bit, we started using it, and this has now been combined with various other procedures to give the vascularity. This was another procedure we tried at one time, the trap tooth procedures. But now we come to free fibrillar grafting, which we have been doing in most of the centers across the country, and there have been very good reports in 2005, and then there came another thing, that was muscle pedicle graft, which was also supposed to be good, from a report from India by Dr. Bakshi, with then excellent outcomes at 10 years of follow-up. But when you look at the latest follow-up, again from in India, it definitely helps that sartorius muscle pedicle iliac bone graft are likely to be a good management protocol in these cases. We had about 59 patients where we have done a core decompression with a non-vascularized fibula. The results were little lesser, 76 and 78, but we were selecting these patients who were still advanced stage of the disease also. So we are quite this thing with the outcome as such in this kind of a situation. And the outcome world over has been almost similar, not as good, but not really very bad at that stage. Then it has been tried at trabecular metal and various tantalum techniques, Velcro cell. Now we're talking about osteotomies. Osteotomies are a difficult situation, especially the rotation osteotomy, the osteotomy of vascularized graft. There has been various results of the osteotomies also, but not a simple procedure for everybody. Cementation of femur head came as another option, and there has been a paper by Hernig also that yes, it could be one option. People tried osteochondral grafts. People tried these grafts as for that area, umbrella-shaped memory alloys, and osteonecrosis by hemicap surgery. But lately we have a paper on bipolar hyperarthroplasty saying after reaming you can create a good incorporation of that cup and you can get a good results. Regarding hyperarthroplasty, there are many choices of bearings, and it was considered it's not a good option in a case of avian as compared to a general OA, but one of the latest literature says in 2016 it is not as bad also. It is reasonably equivalent, except for the revision rate is a little higher. That is what it is. And what is seen that if we had done a previous, just half a minute. Yeah, if we have already operated for any osteotomy, the outcome of THR will not be as good in this kind of a scenario, which can be well accepted. So lately in 2015, we published all these observations, whatever we had up till 2015, another current concept review in Indian Journal of Orthopedics. So what we see today, that if we have got an early stage, core decompression alone is sufficient in a stage which is pre-radiological, we can say, only seen on MRI. If it is already within X-rays availability, then probably getting a graft, whether graft cells or graft, could be useful. When we are likely to get a collapse at this stage, we need a kind of a mechanical support to the area, and we have lost that game, then we need to give the arthroplasty as an option. And if you look at this, one of the concepts given, we add bisphosphonates. You see, whatever the stage is, in all those stages as a part of management protocol, because this is the best compliance available with this kind of a therapy. Thank you.